like to would like all the members, all the interns and students to please clap.
गुड मॉर्निंग। डॉक्टर मनोज गोयल लेना है। डॉक्टर कम है, फिलोसफर ज्यादा है। बहुत सालों की मुलाकात है, इसलिए ये कह रहा हूं। डॉक्टर अमित बिहारी काफी सालों से इंटरेस्टेड, वेरी गुड हार्टेड एंड गुड सर्जन। I have been invited in many of the maxillofacial or dentistry. अब तक काफी लोग क्लेम करते हैं कि मैं बीडीएस बैकग्राउंड रही हूँ, इसलिए बताना जरूरी है मैं कबाब में हड्डी हूँ। मैं बीडीएस बैकग्राउंड का हूँ। डॉक्टर महालक्ष्मी चली गई शायद, जैसे लक्ष्मी को ही सब पूछ रहे हैं, आज तो महालक्ष्मी भी हमारी। ऑन ओरल मैक्सिलोफेशियल सर्जरी डे, कल है ना? There is actually three Valentine Day, मैं ऐसे ही याद रखता हूँ आप लोगों के लिए। Day for you people, लेकिन आपके सीनियर्स डॉक्टर गोयल जैसे जो लोग हैं उन्होंने बड़ा सिलेक्ट करके रखा। कुछ काम की बात है, कुछ प्यार की बात है, दोनों साथ हो जाएंगी, इसलिए आज ही रखें। टॉपिक obviously it will be oral cancer, but you all learned people, especially in the era of 5G, when you can retrieve all kind of randomized controlled trial meta-analysis and data related to cancer, and that too in the era of artificial intelligence, you can get everything on your thing. Whatever I tell you that can help you when you are sitting as a doctor. हमारे शास्त्रों में कहा गया विद्या मित्र प्रवासेषु भार्य मित्रम गृहेषु च व्याधि तवास्थम मित्रम धर्मो मित्रम मित्रस्य च। जब विदेश में हो तो विद्या ही आपके मित्र है। भार्य मित्र गृहेषु च, घर पे पत्नी, बीमार होने पे दवा, और जब अंतिम समय हो तो जो आपने किया है वही आपका मित्र। चाणक्य ने कहा था पुस्तकेषु च विद्या पठस्तेषु यदा धनम उत्पन्नेषु च कार्येषु न स विद्यानां धनम्। पुस्तक में रखी विद्या दूसरों के हाथ में गया धन जरूरत पड़ने में कभी काम नहीं आएगा। तो जो आज आप समझ लें, आप डेंटिस्ट्री प्रैक्टिस करें, कैंसर सर्जन बन जाए, लेकिन उस समय 5G आप खोल नहीं पाएंगे जब मरीज आपके सामने बैठा होगा। जो बातें दिमाग में आ जाएगी यही परमानेंट होगी when you are sitting in your chamber. Basic philosophy, what is cancer? Everybody knows normal cells, almost 30 trillion cells contributes to a human body. We are constituted by 30 to 40 trillion of cells. Few of them become abnormal, started proliferating, migrating from one organ to another, that is cancer. Very simple. How we can detect it early? Only two steps are required. Make the people aware, each and every individual, and make the doctors aware. That's all. There are only two things. Awareness. डॉक्टर को कैसे अवेयर होना है? आप लोगों ने शायद मूवी नहीं देखी होगी। There was a movie Specialist. There was a lot of bomb blast in US. उसके उस समय मूवी बनी थी। The specialist was trained how to suspect anything can be formed. Therefore, any symptom, any problem in the oral cavity not being treated, not being healed by your conventional treatment, suspect it can be oral cancer. That's the basic philosophy. This slide is very important for Indian scenario, Western world and India. Indian oral cancer can be treated as per the Western literature. Answer is no. I'll tell you there are certain points why. Habit in Western world, smoking is common. In our part, chewing form of tobacco, either hookah, candy, this is common. Age, middle and elderly age detection more common in Western world. In our population, it's young age. Sight, tongue and fluid of mouth. That is central compartment of the oral cavity is most common sight in Western world. In our part, it's the lateral compartment. GB sulcus, alveolus, or buccal mucosa. Oral submucous fibrosis practically absent in Western population. It's very common in our population, delaying early detection of oral cancer. In socioeconomic status, medium and high class society usually suffer in Western world. In our society, it's a poor labor class people more commonly affected. Stage 8 presentation, 70 to 80% of oral cancer in Western world present either in T1, T2 stage. In our country, it's a T4, T3 usual presentation. National protocol, they have a strict national protocol. In our country, we have protocol, but not being implemented and executed properly. Health insurance, government covers health insurance to all the people. In our country, it's out-of-pocket expenditure more than 80% of the people. And load, you can compare in the Western world and in our setup, when you compare the load, the oncosurgeon at Royal Marsden is my friend. He operates 4 head and neck surgery in 1 month. I operate 7 to 8 per day. That's the difference of load. Therefore, if you want to replicate Western literature and reproduce the same result in India, it's not possible. As a dentist, can we contribute something in oral cancer? The answer is yes. You can contribute in prevention of oral cancer. You can contribute in early detection. Country, the uniform national protocol can be executed through you people and ultimately will improve the cure rate. Why I'm saying this? Dental practitioner can turn the wheel around. Why I'm saying this? You have all those symptoms, patient presenting to you first, like non-healing ulcer, bleeding gum, loose teeth, ill-fitting denture. They usually present to dental clinic rather than medical clinic. And you have good dental chair, light, and oral mirror. So that you can look at the nooks and corners of the oral cavity to detect oral cancer. Be meticulous, examine the oral cavity as per the side, upper and lower level mucosa. Very unawareness in the society. People are not aware. जब दांत सड़ जाता है तो निकलवाने के लिए जाना बस इतना ही होता है. And sexually transmitted infection and poor oral hygiene. This gutka, everybody is aware. No need to talk much about what gutka has. A form of business. Again is oral cancer, sometimes lost to life. This is classical gutka cancer. ये बड़ी अच्छी स्लाइड है. एक बच्ची बसंत कुंज के रेड लाइट पे मेरी गाड़ी रुकी थी, तो छोटे बच्चे को गोद में गुटखा खिला रही थी. मैंने पिक्चर ली, फिर मैंने जब पूछा कि क्यों गुटखा खिला रहे थे, तो 5 days से. There are more than 4,000 chemicals, and usually people start smoking for a kick, but they are not aware they are taking. There are many chemicals present in the waste product, and 70 of them are carcinogenic. Sharp teeth is a very common presentation in dental clinic, and human papillomavirus, oral hygiene. Oral lesion grossly you can divide in 2 types: pre-malignant, that is baby cancer, and malignant. Leukoplakia, erythroleukoplakia, oral submucous fibrosis, lichen planus. These are the more common pre-malignant lesion encountered in our part of the country. This is a classical leukoplakia. When you biopsy any white lesion, in 30% cases you get either hyperkeratosis, dysplasia, carcinoma in situ, and invasive being classified clinically or any of the findings. No growth. Therefore, don't ignore it. Heterogeneous leukoplakia, erythroleukoplakia, more chance of malignant transformation. Oral submucous fibrosis, oral lichen planus. These are the common presentation. Treatment, either medical or surgical, depending on the type of pre-malignant lesion, you can decide. This is a classical oral cancer. Usually present with reduced mouth opening, red or white lesion, premature fall of teeth, loosening of teeth, or simply as swelling. Even patient was not aware that having lesion in the alveolus or papillomatosis. These are the confusion lesions. You can encounter a kind of keratotic lesion near sharp teeth, ulcer. You may think it may be traumatic ulcer. Therefore, these are the common presentation of the oral cavity. Biopsy, when you have to do biopsy, when you have high index of suspicion, especially if the lesion is solitary, single lesion, you have given all kind of treatment like antibiotic, local application, whatever you have done, but it's not healing for 3 weeks. Suspect it can be oral cancer.
Second, especially if it is indurated, when you are palpating the lesion, margin or base of the lesion is indurated. Suspect it can be associated with cervical lymphadenopathy or present. Ask, cancer spreads when touched with a knife or needle or metal, any kind of, मतलब लोहा लगने से कैंसर बढ़ जाएगा. This is it. FNSC has almost no yield for oral cancer. It's a biopsy is the solution. In the entire oncology, there are only 3 situations where we don't need any psychological or pathological diagnosis before proceeding for treatment. That is the renal cell carcinoma, ovarian cancer, and gallbladder cancer, when resectable on imaging. Only 3 situations. Best all, before treatment, biopsy or cytological documentation before starting oncological treatment. Many methods. Scrap cytology, now out of question. No benefit in oral cancer. FNSC, very low yield, don't go for it. Incisional biopsy, never do it. I'll explain why. And incisional biopsy only when the lesion is endophytic and submucosal. Then only go for incisional biopsy. Then what is the answer? Why I'm saying of my fellow? Small lesion, very much tempting that in dental clinic, on dental chair you can exercise it. Very simple. But he didn't do that. He took a small biopsy and left the ventral suture in place. And ultimately report came out as commercial carcinoma. Now epicenter is there. We can locate where it previous lesion was. So then we can take the proper margin all around. That's the reason, even if lesion is small, you are suspecting excisional biopsy is not the answer. Never accept. Always people are searching for alternative to biopsy. Doctors search for alternative to biopsy. Either they are confused or they are scared or phobic because of bleeding or risk of spread. That's the only one. Answer is punch biopsy. Very small instrument, very handy, can be kept at clinic, and biopsy can be done in any of the situation. Local anesthesia, punch biopsy forceps, formalin bulb. That's all. Nothing is required. But lesion like this can be biopsied. This can be biopsied. Even patient with trismus, because with this instrument, you don't need to put any of the suture. Then even patient is having trismus, you can take chunk of the tissue and deeper tissue. Punch biopsy under process. Put that biopsy sample instantly, immediately in the formalin, buffered formalin solution and label it. So with a lot of mixing of the tissue, cancer patient being diagnosed as non-cancer, non-cancer being diagnosed as cancer just because of mixing of the sample. Therefore, first fix in the formalin solution, tap it and label it. Expectation from oral pathologist. We have done the biopsy, after a few days report came and something is written which appears to a clinician as just something written in Chinese. Crushing, autolysis, never put in normal saline, autolysis artifact must be there. When you diagnose the case, staging forward. For any bony window, CT scan is the tool when it was invented, especially for country in Northeast Asia, Southeast Asia, because of rampant tuberculosis. PET scan after staging the disease. Then we started collecting the data. Previously, it was recommendation for residual disease, recurrent disease, post-surgery, post-radiotherapy, and suspicious finding on conventional imaging. That was the indication for PET scan in head cancer. But we started collecting the data. And in our series, we found synchronous primary of esophagus along with oral cancer after doing PET scan. There was no investigation which can detect patient is having oral cancer and CA esophagus, means two malignancy in the same time. Only PET can do that. Another case, metachronous primary, means head and neck cancer treated. In follow-up, PET scan showed another lesion in upper esophagus. Because the aerodigestive tract, same field cancerization, patient can develop either synchronous or metachronous primary. Only PET can do that. Then this is carcinoma lung in case of head and neck cancer, two separate primary detected in PET scan. And this is in adrenal, and one case was in CA colon, means oral cavity with colon carcinoma. Therefore, In T3, T4 lesion, PET scan is the primary modality of staging as per my series. Planning is very important. There is a concept of 3M. When a patient of oral cancer comes to a clinic, usually doctor get biased. That should not be the answer. When I joined oncosurgery, I did my MS from Aligarh. My teacher asked, क्या कर लोगे oncosurgery में? ज़्यादा निकाल लो. Remember. Then we learned how much to cut, what should the margin, extent of dissection. Then we learned when to cut. And after 10 years of practice, we learned when not to cut. And that's the most important thing in oncosurgery. Cancer is an unpredictable disease. It has not read the textbook of America. It's a lawless disease. It's written in the Bible. Everyone who makes a practice of sinning also practices lawlessness. Sin is lawless. So is the cancer. Therefore, never localize to one organ. It can spread from one organ to another. It's always close to major vital structure. You have to be very meticulous. It's a classical case of composite resection or commando operation in loose terminology. In Quran, it has been written, we have already created man who knows whose soul whispers to him, and we are closer to him than his jugular vein. Tumor spillage, we have to avoid while doing surgery because new spillage of the tumor on the raw surface, local recurrence of the tumor. This is the answer. In Hindu mythology, it has been described monster रक्त बीज है. उसको एक वरदान मिला था, उसका एक बूंद खून जमीन पे गिरेगा, दूसरा राक्षस पैदा होगा. Same with the cancer. We have to avoid exfoliation of the cell. Remember, first chance is the best chance. Radiotherapy and chemotherapy cannot compensate improperly done. For dentistry, we call the DAVE. Triple O is your association and conference. Means oral maxillofacial surgeon, oral pathologist, and oral medicine and radiology people. These three departments combine together and work in coherence, send patient to oral maxillofacial surgeon on time so that can be operated early. That should be the mantra for dentistry. For general conception, for head and neck oncology, there are two broad categories to address when dealing with oral cancer. First is mandible, second is neck. When how to address the mandible and when and how to address the neck. There are segmental mandibulectomy, marginal, and mandibulotomy. Segmental mandibulectomy indications are gross invasion of the mandible or paramandibular soft tissue invasion. We have to do segmental, take out that segment which is involved. Marginal mandibulectomy, mandible is free, but grossly you will not get enough margin 1.5 cm away from the tumor. In that case, we have to do chipping of the mandible. But remaining height of the mandible must be more than 1 cm to avoid fracture. And mandibulotomy, when tumor is posterior, you have to approach it, take out the tumor, and deposit the mandible into mandibular plating. Management of the neck, when neck is positive, no confusion, we have to do neck dissection. When neck is negative, Mandel Hull criteria is there, which guide us when to address the neck and how to address, means what kind of neck dissection can be done. Neck dissection classification, detail can be, it's a long topic, can be taught in different lecture. This surgeon's eagle view of head and neck cancer surgery of this is the configuration of operation theatre. This is patient positioning so that you can operate on the neck head area. At the same time, anesthetists can work. So that where should be anesthesia work station, how you place it, how assistant will stand, everything is very important in head and neck surgery. This is positioning of the patient. Up, neck extended and turned opposite from the operating side. Position, pressure point must be avoided because chance of PET also prolonged field pressure, sore while patient lying in the, it must be taken care by the surgeon. Then position of surgeon and equipments. This is anesthesia part. Patient safety is very important. That you can see red. This is because endotracheal tube, because we intubate patient through nasal route, and nasal necrosis is a common problem in the post-operative setting. This is anesthesia Polish catheterization to monitor the urine output, eye safety, blood pressure and antibiotic before starting the surgery. intraoperative monitoring because we need hypotensive anesthesia during surgeries. Draping, again, is proper training how to drape head and neck cancer cases. These are the incision. Cryle, Schopinger, Conley, McAfee, Hyde, Martin, there are many incisions you can see. But this young fellow, YouTuber, very famous YouTuber, he suffered from tongue cancer, total glossectomy, bilateral neck dissection has been done. But you can't see any of the incision except tracheostomy incision, small incision here. This is robotic surgery for tongue and bilateral neck. This is small lesion, laser excision has been done, excised. This was the specimen. Small specimen must market the margin, lateral margin, medial margin, superior margin, so the pathologist can tell you which margin is how much. Carcinoma right lateral tongue. This was the case when I asked you, don't go for external biopsy, small lesion. Classical Cryle incision, neck dissection, intraoperative dissection. This was the specimen, small lesion, taken margin all around. In 1972, and after doing 11 flap, he discarded because flap didn't survive. Then IV started. This was the dissection, dissected the specimen, and this is reconstruction with platysmal biomechanism flap. China had largest series of 11 cases when I started this flap. Now we have crossed 3,800 cases of platysmal biomechanism flap with very good result, and we published this because we modified the technique. This is post-operative result. Carcinoma buccal mucosa, T4, specimen involved, which major microgram flap. One pedal inside, one dissection, specimen, free fibula flap taken from the leg area, multiple reconstruction and in the same sitting. After doing MBAs, there are certain areas you have to cross more than the oral cavity. For example, this is basal cell carcinoma of the nasal area, excised, median forehead flap, skin and neck cell tumor, excised, primarily closed, came to be long back. He was being treated with chemotherapy, squamous cell carcinoma of the skin, chemotherapy, because of lack of availability of surgery. But fortunately, brain was spared. We did craniofacial resection, taking out the entire pelvis, everything, and reconstructed with free flap. Carotid body tumor, Champion type 3, excised, laryngopharyngectomy, ballistic neck dissection for carcinoma larynx. Interesting case, same laryngopharyngectomy patient, permanent tracheostoma, came to me. उसपे पे बीड़ी सिगरेट से जला हुआ निशान था. मैंने पूछा सिगरेट पी रहे हो? मुझे भी लगा कैसे पी रहा होगा. लाइन तो निकाला. ये हमारे हॉस्पिटल के बाहर खड़े होकर बाउंड्री के पास से बीड़ी पी रहा है. From tracheostoma. Therefore, your job never ends in the OT. It's always to follow the patient. क्योंकि यही केस फिर सीए लंग लेके रेफर करेगा आपके पास. This is process. Now, what is need of India? Because I am also managing graduate. We have to understand need and want. If our politicians and rich people like celebrity, they want, they can go to US or Singapore to get their surgery done. That is want. What is need of India? When we call India, India is not Delhi. India is this. When you start traveling from north to south, east to west, you'll recognize the basic cancer surgery, basic oral cancer surgery facility is not available. That is India. And we are talking about the robotic surgery. That is India. The cancer burden in US population of all malignancy, only 3% are oral cancer. In our country, it's 30% of all malignancy. In our setup, it's a young adult population. 80% population in our country are below poverty line who are getting oral cancer detection. And lack of oral examination, this is government data. 70% of the public hospital, they don't have dental chair. 70% of public hospital in India. Oncology dependence of 75 years, we have not crossed 2% of the GDP. Currently, health budget of India is 1.9%. Why this is failure of national policy? This paper I published, oral cancer incidence trends in Delhi is rising, 1990 to 2014. When tobacco, means gutka was banned in Uttar Pradesh and Delhi, after that, still it is rising. Why it is that? This is the only three reasons I concluded. Corruption, non-inclination of the government of India, means any chemotherapy and consumables. Cancer treatment is costly. What is costly? Chemotherapy and consumables. Who decides the rate? Doctors? It's the government. 492 drugs of cancer have been capped now, saying that these are the essential drugs. Then I asked, what are the rest of the drugs? People wake up in the morning, start eating drugs. Then these are not essential drugs. Chemotherapy minutes. Just because chemotherapy has some cuts and commission for the doctors and the hospital, those cases which can be treated by surgery or giving, those cases are being treated with chemotherapy just because of vested interest. Comprehensive cancer care, there are very few hospitals who has comprehensive cancer protocol and cancer setup in India. The private sectors are catching very few people and large in number, more private setups. Public sectors catching a lot of people, but very small dedicated cancer setup. That is a scenario, inverse pyramid scenario, Baba therapy. Anyone can treat cancer. Baba by Gaumutra and Gobar can treat cancer. Doctor never raised their voice that cancer cannot be cured by Gaumutra. Or any Baba for that matter, not only one Baba. Alternative treatment. People ask for alternative because cancer treatment is not available, cancer treatment is costly, and Baba can cure with Jharpur, Bhavut and Gaumutra and Gobar. These are neglected cases because that Baba sit on the television and says, doctor, टर करता है. तो उसके भी कारनामे मुझे डॉक्टरों को भी दिखाना जरूरी होता है कि उसी का ट्रीट किया हुआ अर्ली स्टेज कैंसर है जो एडवांस स्टेज किया है. These are neglected cases in मेरा भारत महान. इसको मसल कार्सिनोमा स्कैल्प, CA larynx being treated by Baba. These are cases of early buccal mucosa cancer now become T4 by treatment by Baba. These are real scenario. Therefore, up to this stage, my recommendation to the doctors, to the stakeholder, to the policymaker are to start creating dedicated cancer center across the country, decentralize the centers. Uniform national protocol must be executable. There must be regulation of Baba therapy, like we have Dental Council of India. There must be Baba Council of India who can regulate which Baba can cure cancer, which Baba cannot cure cancer, and what are the protocol Baba is following that can be regularized. Drug price control must be there for cancer patients. Decentralization of facility across the country. Moral responsibility of the Indian oncologists to train their next generation, next batch, and make more and more oncologists so that cancer treatment can be uniform and available across the country. Recruitment of other specialties for early detection like OMR people and those who just have done BDS. We have started running was a stewardship program for BDS intern. Those who are not interested in doing post-graduation, going for starting a clinic or joining government setup, they should be able to detect early lesions. That should be the training part. Media involvement on healthcare and improving the health budget. These are my recommendations to the all stakeholders. There are few case capsules. This is 62-year-old male presenting chief complaint of swelling in the neck. FNSC is commercial carcinoma on taking history and examination. Declared as MUO, metastasis of unknown origin only in the neck, no lesion elsewhere. When I came out of the OT, just re-examined the case, there were two lesions, one in the retromolar trigon, another at the lingual surface of the alveolus, small lesions, just missed by fellows during examination, that's all. Means meticulous clinical examination is the answer to detect oral cancer. Case number 2, small ulcer at the cusp, sharp cusp. क्या करेंगे आप लोग बताइएगा? Small ulcer, sharp cusp. You have done grinding and everything. Ulcer is not healing. What do you do? Take the biopsy. So first biopsy, prove or disprove. If it is not cancer, extract it. No problem. This kind of growth, imaging of choice, CT or MRI. Perfect. Soft tissue, MRI. This is for neck dissection. When we talk about cancer, everybody is afraid of recurrence. Remember, our aim should be there, should not be local regional recurrence. Where we have operated, cancer should not relapse at that area. Otherwise, entire universe is following the phenomenon of afraid. The cockroach is afraid of mice, mouse from cat, cat from dog, dog from man, everybody knows. And she again from cockroach. Therefore, don't be afraid of cancer. It's always myth that cancer can be treated at big surgeon at big hospital because it is big surgery. Fact is, it just requires proper planning, optimum setup, and skill hand. Nothing is required. Always, it should be integrated protocol, integrate all the department, and treating a spot. There are two components: hospital and doctors.